Hey everyone, welcome back. I am Dr. Shayna Powell. I have recently changed my last name to my husband's. I am a naturopathic doctor and owner of West Oaks Wellness here in Montrose. Today my guest is Dr. Jillian Horkin. She is a DDS, Doctor of Dental... Yep. I'll have her introduce dental surgery. I'll have her introduce herself. She is the owner of Montrose Dental Wellness here in Montrose, Colorado, and I'll let her give you a little intro into her background. But these are the things we're going to kind of talk about. We're going to roll forward on today. Our interest in oral health as it's related to systemic, so your whole body's health. Fillings, both amalgam and composite, pros and cons, like everything else in the world. We're going to talk a little bit about sleep-disordered breathing, symptoms that might be associated with this. Many of us know sleep apnea, but there's a spectrum like so many things in health. It's not just sleep apnea. And then we're going to talk a little bit about fluoride and nano-hydroxyapatite, because these are things that are currently going on in the marketplace. We're not going to get into a fluoride argument, but, you know. All right, Jill, I'll let you take it away.
Thanks so much, Shayna, for having me. I'm Jillian Horkin, and I'm a practicing dentist here in Montrose. My company is Montrose Dental Wellness, and I started my interest in dentistry when I was young, wanting to go into healthcare to work with people and their health. It evolved over years and years, but when I was 18, I decided that dentistry was what I wanted to go into. And then throughout college and kind of working in the field, seeing if I liked it, I just happened to continue to want to work and grow in that capacity. And I graduated from dental school from Creighton University in 2014, and then moved out, did a residency in public health, and then saw the challenges that face public health. There was a lot of help that I wanted to give, but also felt like my hands were tied. So I had an opportunity to go into private practice, and I did that in a group setting for about 9 years. And then recently, after having graduated from the Coy Center in Seattle, it's a postdoctorate training program, having taken the knowledge that I learned from them, the evidence-based approaches and the wellness aspects of the total systemic health, I wanted to branch out and start my own company.
Nice. I like it. Yeah, I'm sure you saw some really interesting things working in public health.
Yeah, it's, it's a worthy cause and sad at the same time.
Yeah, a lot of head banging, I'm sure.
Yeah, yeah. The red tape is frustrating for anybody.
Yeah, it's tough, and also those are the people that need our help the most too. And I know that my patient population is probably similar to yours, and they're like a little more, they can afford our services or they have dental insurance, etc. And you know, when I have tried to be a little more subservient to the population that needs my help more, it's difficult because there's so many obstacles for them.
Yeah.
You know, whether it's like they live in an abusive household, or they can't get to school, or like brushing their teeth, like, you know, all these, like, there's simple things that, you know, to you and I are like, well, duh, like, that's just go brush your teeth. Well, it's not always that simple when you live in a dysfunctional household.
Right.
You know, one parent that's working 2 or 3 jobs, you know, someone's substance abusing, like, it gets complicated quickly.
Right.
Unfortunately.
Yep. And I think in that aspect, what I witnessed, there was large financial barriers, which frankly, the state, the Colorado Dental Association that I belong to and work as a delegate with, they have removed a lot of those barriers.
Nice.
So care is available. It's just that there's still a lack of understanding. And frankly, a vast majority of people don't see a dentist. So there's a lot of public fear mongering.
Yep.
There is fear of the unknown, fear of what could happen, and it's a personal space, right? Having someone in your facial bubble can be uncomfortable at times.
With your mouth hanging open too. I saw a chiropractor before I saw a dentist. I had a lot of dental issues when I was a kid, and my mom we couldn't afford it, so we just didn't.
Yeah.
My interest in oral health, you know, I used to joke, because I wanted to be a doctor since I was a kid too, and I used to joke, I'd rather be a proctologist than even think about the mouth. And, you know, I'm a GI kind of focused naturopathic doctor, and, you know, I found myself in college dealing with my own health issues and not really getting good answers, and so I started like looking at my body. What other signs are going on? And I had this thick, nasty yellow coating on my tongue. It could come off, it didn't bleed, but no one had any answers for me. And I was like, what is going on here? And so then noticing those other mouth symptoms I had, because I had severe acid reflux,
Right.
it was like, okay, so this is telling me that I haven't resolved the problem, even though I'm not experiencing the same symptoms I was a few years previously. So it kind of clued me in. And then as soon as I started working on my gut health, my mouth stopped having cavities, stopped having a weird coating on my tongue. So it's like, this is something in clinical practice, all new patients, they get a thorough mouth exam. I'm not putting my fingers in their mouth, but like I'm looking and seeing, like, is there anything that I need to make sure they get to a dentist for, or not? Do I need to screen them for sleep disordered breathing?
Yeah.
It's a major cause of systemic health issues.
Absolutely. Absolutely. And that's where I have shifted the focus in my practice to try and be more comprehensive, not just in dentistry, but understanding the systemic link between what's going on in the body and what we see in the mouth.
Yeah.
Because everything from sleep disordered breathing, acid reflux, autoimmune diseases, cancers, cardiovascular issues all show up in the mouth. And oftentimes, if you are somebody who goes and sees a hygienist twice a year for hygiene therapy, or if you have gum disease and you're seeing them every 3 months or 4 months, we're seeing you that much more than maybe the average person might see a physician or
That's
a
true.
naturopathic doctor.
Totally.
And we have the opportunity at that point in time to say, hey, this doesn't look normal, or this doesn't look healthy, something's off, and have that conversation and get them back to their physician so that we can have a deeper dive into what's going on.
Yeah, more touch points.
Yep. And so knowing those things, seeing them, and saying, hey, here, I see this, tell me a little bit more about it, has been a huge opportunity for us to play a bigger role in the patient's overall health. I don't have to treat it, right? I'm not trained to treat those things, but too many times I saw that things were ignored, and it's like, there's just something here that's going on and it's not normal.
Yeah, absolutely. Yeah, one of the other things I see sometimes is kiddos with behavioral issues that have some kind of oral dysfunction going on, and that's how it presents for them. And it's like, kind of makes sense. It's like something is irritated, and everybody is going to manifest it slightly differently. Somebody might manifest it with like snoring and like high blood pressure, and other people just whatever system, I call it the system of weakness.
Right.
It's like whatever the person's predisposition is naturally. For me, it's my guts. For some people, it's their nervous system. For other people, autoimmune tends to be the thing that they trend towards, right? Okay, so interesting. So most people know periodontal disease, which is the receding gums and getting bacteria into your bloodstream associated with cardiovascular disease. Am I understanding that correctly?
Yeah, it's not far off. So what periodontal disease is commonly referred to as gum disease is an inflammation of the hard tissues. So there is inflammation and bacteria below the gum line that because of the nature of the inflammation and the body's natural response to fight it, your immune system response, it's going to break down bone. And the tissues are inflamed.
That's not good.
No, not great at all. So what happens is, as that bone breaks down, the tissue can recede. If it doesn't recede, we get deeper pockets. When it's treated, it's not inflamed, we get that recession. If the tissue recedes, now we've got a couple problems. One, roots are can be exposed, and you can be prone to root recession, root sensitivity. And if you have the pathogens in your mouth, a high concentration of them that cause periodontal disease, not often, but on occasion, we can also have the pathogens or the acidic bacteria that also cause cavities. We don't need as large of a drop in pH imbalance to cause root decay as we do for decay on enamel.
Okay.
So what happens is you're more prone to sensitivity, and if you're prone to both, that root can be really susceptible to breakdown and disease.
Right, because it doesn't have enamel. It doesn't have the protection. The gum is supposed to be there.
Right. Roots are made on the outer coating of cementum, and so it's a much softer material.
Got it.
Enamel being even harder than bone. It's the hardest material in our body. And so it breaks down easier, not just to decay, but also to mechanical brushing. Most people have no idea how much pressure they're putting on their teeth when they brush their teeth. That in itself can cause recession. The U.S. does not do a great job about disclosing things about products such as toothpaste and what their abrasivity is. So all over other countries, we have something called an RDA, a relative dentin abrasivity value. And that has an effect on when we start getting into the softer tissues and you putting pressure and applying that, we're putting really harsh pace and breaking tissues down.
Yeah, I feel like a while ago I did something about this because Sensodyne is for sensitive teeth, but it actually has a very high abrasive index compared to something like baking soda. And I was really surprised by that because it's like supposedly for people that have sensitive teeth, but it makes it more sensitive in the long run.
And it depends on which Sensodyne we're using. So Sensodyne, anything with whitening, always going to have a higher abrasivity. That's what whitening toothpaste does. It's more abrasive, and you are scrubbing away stains essentially. The irony is that it can also scratch your enamel. If we look at our enamel under electron microscopes, we see that higher abrasivity past 22, past 100 on the RDA scale. We're going to have some of that that scratching, which is then traps more bacteria and stain.
More surface
so
area,
it's I think a bit of an irony that we're using some of those things to remove surface level stains, but we're also scratching the surface, which means more staining potential.
Right.
So so ironically, when we look at an RDA value chart, same brands but different different toothpaste within that same brand can have different RDA values.
Sure, that makes sense. And then the other thing is like, why do we even sell medium and hard bristle brushes when we shouldn't be at all?
Yeah. If I could go buy all the hard bristle brushes in the grocery store and throw them away, I would. We always want to use a soft bristle brush. I have seen even my own family members in generations before me that have literally scrubbed their teeth away. And you just look and you go, oh my gosh. But yeah, the days of using wire brushes should be long gone. We don't want to use wire brushes for our teeth.
Ouch. That is just like, I'm thinking about like scraping like an infected wound. Like I'm like, ooh, we don't want that in our mouth.
Yeah.
But that is so interesting that there's even products that we were well known. So flossing and using a soft bristle brush, I did not learn until I was in med school when I was seeing a fantastic dentist.
Yeah.
There are unfortunately not enough of you guys that are like really good at explaining and helping people do a better job being, how do I say this, in charge of their own dental health.
Right.
It's like when the lady showed me, or the hygienist showed me how to do flossing, and it wasn't just, you don't go straight down, you go on the edge of each tooth. And I was like, oh my God, I am way too old to just be learning this. Like, this is why I didn't like flossing, because it hurt. Like, actually, I was damaging myself.
Yeah. And we talk with our patients too a lot about education and what proper actual brushing looks like. There's so many different techniques out there. And depending on each individual needs, do we have recession? Do we have sensitivity? What type of tissue architecture do we have? We're gonna make recommendations based on that for proper brushing. The flossing I always find interesting because so many of us, especially with the invention of floss pickers, and I'm not harping on floss pickers, but if you're going to use a single piece of floss on a pick, by all means, like, use what you can to floss, because many people don't.
Right.
But that in and out really doesn't actually get to the point of what flossing is about. We need to use floss in a way that we encompass the side of the tooth and really give it that C-shaped bear hug up and down a couple times, because what we're trying to remove is that bacteria biofilm. And if you go in and out, if you think we've got a triangle and we just go in and out, there's a whole underscape here that we're missing. And so when we floss, it needs to be rounded around that side, because that's the areas where simply the bristles of the toothbrush are too big and they can't enter in.
Sure, that makes sense. And these are the sweaters on your teeth. I've heard someone call those terms, right?
Sweaters
like
on
that's the
teeth.
biofilm.
Yep. I tell, when I'm talking with kids, I say, if you have the kind of dishwasher that you put the dishes in and you didn't scrub it off before, and then it comes out and it still has the food stuck to it, I said, that's like your teeth not flossing. You're leaving debris on there. And so, little teeth sweaters. But bacterial biofilm is a serious disease. It's what causes gum disease. It's what causes cavities. So when we look at gum disease and the body's own host response and how it responds to that, it's very destructive and can be. Totally. And depending on our genetic profiles, some people are more prone to it, some people are less prone. So we see tooth loss, we see inflammatory markers, which then plays a huge role into our cardiovascular system. We know that if we have a positive confirmation diagnosis of periodontal disease and it goes untreated, we are 3 to 4 times more likely to develop a heart attack or stroke. We know that it impacts the brain, it impacts the heart, impacts the gut.
Yeah.
There's very few systems it doesn't impact.
Yeah. I had another dentist I did an Instagram live with, and her background was in lower intestinal cancers associated with the mouth, and how interesting that was. And she's like, it's not so much swallowing, it's just like if it's here and that is telling us that systemically something is off, then you're going to have more inappropriate bacteria throughout your entire GI system.
Right.
I thought that was so interesting that testing the mouth can tell us our risk factors for certain types of colon cancer, which is on the rise in the United States, which is very concerning. It's no longer 50 plus. Now we're seeing it in like 30-year-olds. Right. Much more commonly than we are in our older populations.
Yeah, I think that the advent of salivary diagnostics is going to start playing bigger and bigger roles in prevention and care.
And salivary diagnostics is like pH and like microbiome of your mouth?
Yep. So there's a couple different ways that we do it. In my office, we do a chair-side test where we'll check the pH of it, we'll check your saliva buffering capacity, and then we also screen for resting and stimulated saliva.
Okay.
Right? So we're looking at patients who have autoimmune diseases and maybe not a lot of saliva. How quickly is that saliva forming when you're at rest? How quickly is it forming when it's stimulated? And then what's its ability to buffer? Because the whole saliva plays a really important part in our mouth in being able to buffer and balance out the acidity of our mouth. And so if we buffer out that bacteria and we're washing things away, that's what it's engineered and designed to do. If we can't do that and we have a low buffering capacity or we have a super acidic pH, that's where bad bacteria, pathogens, gram-negative, streptococci, they're going to form and they're going to take over, and that pendulum shifts and we have big problems.
Yeah, that makes sense. And so before we were kind of deciding if we were going to talk about fluoride, and I think this is kind of an appropriate time because before we started recording, we were talking about how some people, especially that have a lower pH in their mouth, which the normal pH is supposed to be neutral, 7, sometimes fluoride is necessary. And we were discussing the differences between fluoride and nano-hydroxyapatite and like pros and cons there. Yeah. Let's chat about that.
Yeah, so there's been a lot of chatter lately about, there's always chatter about fluoride. We know it's a known neurotoxin, and we have to look at it from a standpoint of at what level is it toxic, right? The ADA has come out to lower water fluoridation to say that we want it around 1 part per million, and it's been effective in communities who have no lac. In my residency, I did see people with fluorosis. They were predominantly from either Mexico or Central America in areas that had massively, like insanely high levels of fluoride in the water. And so that can absolutely be detrimental. When we look at it in where we live and where everybody else has lived, we have to remember that fluoride is a naturally occurring element in the water. And so ebbs and flows. Where we live in the mountains, it ranges, and you can call the water board and they'll tell you at any given time, here's our last reading, right? It's at 0.7 or it's at 0.6, 0.5, depends on spring runoff, how much water levels we're going to get.
Totally.
But the interesting thing is that when we look at fluoride and the way it bonds, so fluoride is used to stop and arrest decay and remineralize tooth structure. Nano-hydroxyapatite is what our teeth are made up of. And so when we are using fluoride, we're going to fluoroapatite. And
so instead of calcium, so nano-hydroxyapatite is a calcium component. Calcium and something, I can't remember, but it's calcium based. So basically what fluoride is doing is replacing the calcium.
Right, when we look at that bond, fluoride is always the stronger bond compared to the nano-hydroxyapatite. And the problem is that, as we were discussing earlier, we have all these companies coming to market with nano-hydroxyapatite. We know that it's important that the shape be correct. It needs to be either spherical or sphere-shaped ends of some sort. We know that it has to be small. We cannot throw a big particle size nano-hydroxyapatite and have it actually bond.
Right.
So size and shape have been the big talking points of how important it is, but very few people are looking at the pH environment of what's going on in the mouth. And if we're using nano-hydroxyapatite, we're using fluoride as supplements to someone's oral care that they're not naturally getting or they need extra of. It's typically in cases where we have an acidic environment, we've got a pH imbalance. And the problem with that is that if we're not looking at the mechanism of delivery, the environment of delivery, the toothpaste itself, and we've got a lower pH, nano-hydroxyapatite is already not as effective as a bond than fluoride. And if we have it in an acidic environment, it's not going to be nearly as strong as the bond with fluoride. And so throwing more and more nano-hydroxyapatite in an acidic environment isn't going to necessarily be what shifts that pendulum back over to a balanced mouth.
Got it. So are you kind of saying that the products that are on the market that you're aware of right now that have the nano-hydroxy, very important on the shape and size, which I've heard that there's some cost, which is why these toothpaste cost so much money.
Yeah.
So getting those proper components is very costly. The other aspect I'm hearing is the pH of those toothpastes may not be appropriate for someone that tends towards a more acidic mouth.
Correct.
Got it.
So if you're someone who's very high prone to cavities, fluoride isn't something we usually typically treat gum disease with, so we don't have to spend a lot of time on that. But when it comes to cavities specifically, it's a pH imbalance of certain streptococci bacteria. And if we're trying to shift preventatively, right, not just say, okay, you've got this, the traditional anti-cavity toothpaste on the market have been a higher concentration of fluoride, right? And we're coming out with more either natural or hydroxyapatite concentrated toothpaste, which can be great, but there's only one company to my knowledge that's actually looking at the pH values. So if we aren't shifting that pH over to a more neutral standpoint, we're never going to get the preventative aspect of anti-cavity.
Right, we're never going to solve the issue. And the other shtick that I have about the nano-hydroxyapatite toothpaste is they all are based in glycerin, which is not great for our oral health. So it's like, everything has pros and cons, and it's just like your preference, I guess, preference, yes, and also need. That is important to consider. I definitely discourage people from using fluoride toothpaste, but maybe I will have a different conversation. It's interesting. My biologic dentist, the one class I've taken that kind of got me keyed in to like pay attention to certain things in the mouth, he does not agree that fluoride makes the teeth harder. And so this is really interesting. And my understanding too is that fluoride that's added to our water, and yes, fluoride is naturally occurring, totally. But fluoride that's added to our water actually is a discard product from the textile industry. So it's like a waste product. It's like, how can we make money? This is like your classic corporation. And so this is my thought, and I could be incorrect. And so it's like they're trying to not have to pay to get rid of toxic waste, and they're just putting it in our water and calling it good. I've never lived in Mexico and Central America, but I did live in New Mexico, and I'm pretty sure they had way higher fluoride in their water.
I think it would be interesting to look at a map of where we have those, where we see higher concentrations naturally occurring, and is it because of textiles and different things being put into the water versus, where we live, there is not a textile merchandising situation going on. We don't have those manufacturers out here. It is all Spring Mountain runoff water. And so what does that look like? A lot of fluoridation too is going to come from what the city decides, what the county decides in the water project management. So a lot of the fluoride is manually put into the water for the treatment.
Like in Montrose, we have a lot of chlorine, which I always give this shtick to my patients. We don't want dysentery, so we put chlorine in the water. I don't think chlorine is ideal for our bodies either. So this is another like weird like shtick that I have about fluoride in the water. It's like drinking it, you're drinking the entire thing and swallowing it down. So it's like, yes, it's helping your teeth, but it's going past your teeth.
Yeah. So the issue I am seeing is that there seems to be, not wholly accepted, but a shift in going from fluoridated water from a systemic. The mindset behind that is in children, young adults, where we're still developing and it's still like systemically being incorporated into the development of those teeth, right? And I think it's hard when we're adults and we look at it and we say, okay, I'm not very cavity prone. I don't want it in my water.
Totally.
But we just talked about public health and the most at-risk populations when we have public drinking water and we're not buying bottled water, we're not doing X, Y, and Z.
Right.
They're
Not
the
seeing
ones,
dentist.
we're not saying dentists, they're the ones that this is targeting.
Totally.
Right? And it's not ill-intended, but it's to say, all right, we have free community water and we have these problems. And so it's been effective in preventing early childhood caries and disease because more kids miss school due to dental decay than anything else in this country.
Oh, that is so horrid. And tooth pain is so unpleasant. It's like, so this is the pros and the cons of everything. You and I, we live a more quote unquote privileged life because we can have this conversation and think about the nuance. And then there are people that are barely getting by, that they don't even think about brushing their teeth. And this is the only way that we've been able to find a public health measure to support better health outcomes for a lower income, poverty, impoverished community. So it's like, what do we need to do here? What is better? What's worse? I think that it's a complicated, and I don't know if there's a one good answer.
Yeah, I certainly haven't found one yet.
No. And this is why I love having these conversations. It's like, it speaks to the fact that there's nothing that's black and white in the world. I don't know that I found a single topic that's a little more complicated that I'm like, oh yeah, it's clearly like, besides the fact that this leaf is green. We know that chlorophyll is green. Like that's an easier like solution, but like these complicated questions that we ask.
Right.
And have to consider our own privilege. Yeah.
So we always I think that in any situation it needs to be a respectful dialogue between your doctor and the patient relationship to say, okay, here's the risk profile. What are we going to do to help in lowering that risk? I have plenty of patients who I don't make that recommendation for fluoride or they don't need it. And in the ones who would prefer not to use fluoride or fluoride adverse, we sit down and we talk about the realities of, okay, here's what we can do. This is what's available right now. Yeah. But, the future, things might change, right? As I said, I've tested many of those popular brands of nano-hydroxyapatite toothpaste just in simple litmus paper tests. And they come in right around 7. And if I've got somebody who is highly acidic, we're in a 5 to 6 pH range, I can't get them to a neutral range and slow down the cavities. Even with, doesn't matter if it's 2% nano-hydroxyapatite or 10% nano-hydroxyapatite, it's just not going to happen.
The pH of the formula needs to be appropriate to move the dime. And this is what's so tricky about pH in general. And I only know from like gardening, like that's where I know mostly pH, and I mean some gut stuff too. But it is tricky, the amounts to get things to mix into solution to get the pH to shift. And the pH of our soil in Colorado tends to be really high. Right. Makes it difficult to grow a lot of things.
And just like if it rains, if it doesn't rain, affects how much you can titrate that amount.
Yeah. Our saliva.
What we put into our mouths also titrates that amount. So what are we drinking? Or is it carbonated beverages? Is it soda? Is it juices? Are we throwing lots of sugar at it? Because sugar doesn't cause decay. Sugar is a food substrate for the bacteria and feeds them to replicate much quicker so that they release more acid, and the acid is what breaks it down.
Yeah, totally. And then we're feeding, and thereby they're growing and developing and making more of the same flavor of bacteria that's not necessarily ideal for the pH of our mouth.
Right.
And we were kind of chatting, it's like talking about Mountain Dew mouth, but we don't see a lot of soda drinkers in either of our practices, but seltzer water is very popular. Yeah. It still has a low pH because carbonic acid, right? Yep. Exactly. That's what makes it carbonated. And I don't love carbonated beverages for a lot of gut issues, but they're not great for our oral health either. No. And how White Claws got to be so popular. They taste terrible.
I don't know. I'm not a fan, personally or professionally.
Personally or professionally. I've had a sip of one. I was like, this tastes like diet flavored water. No, thank you.
No, it's interesting because it all comes down when we look at gum disease and cavities in the mouth. It's going to come down to biofilm mediated diseases, biofilm being the protective covering of that bacteria where they replicate, and it's hard to get rid of that, right? My office is trained to specifically target that. We do different hygiene therapy than just about most other offices out there. It's a very specific targeted therapy using xylitol and not xylitol, erythritol. We use erythritol powders because they are anti-inflammatory, but they're also going to kill that bacteria. They're cytotoxic, right? So they engulf it and kill it. And then we look at the inflammation, and that's where it comes back into the mouth is one big mucous membrane. We have a blood-brain barrier, and if there's inflammation here, there's inflammation everywhere else, most likely the gut.
Yeah, I call it leaky endothelial cells. So intestinal permeability is the technical term, but leaky endothelial, our skin, our gut, and our blood vessels are all made of endothelial tissue. It's made from the same embryological tissue when we're forming in utero, and that's why you can have leaky lungs, leaky brain, leaky mouth, leaky any of the same tissue. It's a really good point. Complicated. The mouth is complicated, and it tells us so much about our whole body's health.
Right. Yeah, we see plenty of things early on, warning signs as far as cancers, autoimmune diseases. Cardiovascular disease is a huge one. There is very few things in the world of science that we have been able to prove direct links to, and cardiovascular disease and periodontal disease are hand in hand. Yeah. They're direct correlations.
I mean, that's not very far. Like in my brain, just like thinking like location-wise, it's not far. One of the other things I wanted us to chat about before we talked about sleep-disordered breathing, which has such major implications, is fillings. Yeah. And so there's two main types that I'm aware of, is the mercury amalgam fillings, the silver fillings if you've seen those, and then the composite fillings that can be made to the same color of your teeth.
Right. So there's a couple different materials still out there. Depends on the dentist, their comfortability, what they their entry point, what was taught to them, right? And so in my training, dental schools predominantly serve lower socioeconomic populations. That's just the nature of it. And so I can't speak for all schools. In my school at the time, we placed amalgam fillings and composite fillings. So you had to learn both. Gold was relatively on its way out, mainly because of the cost of gold.
Totally.
So I still see gold restorations. I still do gold restorations. I love it. It's beautiful. That's just my take on it. It's depending on, we can get into a whole conversation of types of gold and concentrations, because it all matters in how it's bioinert and how the body accepts it. But going back to the fillings, what's most commonly recognized is silver fillings, amalgam, which people refer to as mercury fillings, and then composite resin fillings. Composite resin fillings first came out, it was really challenging because everyone's used to working with amalgam. Carves beautifully. Like I can, back in my residency and my dental school days, like you can put beautiful, beautiful anatomy into silver fillings. And it feels good to be able to mimic what was taken. The problem is that one, I think I was sharing with you earlier, is physical retention is predominantly what's used for silver fillings. So if we imagine a tooth shape and we're cutting underneath and we're undercutting, right? We're making closer to the side of the tooth deeper out to the outside than we are the inside.
Right.
We need that to physically retain the filling in there. But the problem with that is over time, I've seen if the patient doesn't have proper bite managed, that can weaken, as we put stuff on there, that can weaken the forces of the tooth. And then also there is this expansion and contraction reaction that happens with silver fillings. And so a lot of people get hung up about the mercury, right? We see that mercury, it's toxic, and it's toxic in that vapor form. So the risk is placing it and removing it, right? While it's in your mouth, it's relatively low risk. There's not as much there. The study that was done where they talked about the chewing, I struggle with that study because it was done in cows. It was also, so it was placed where there was tons of fillings done on the cow, like just about every tooth had a silver filling, large, massive ones.
Yeah.
And additionally, cows don't chew the same way as humans do.
No, and I'm curious if their pH of their mouth is different too.
Right. So we have to look at all that. There was a lot that's not actually looked at in those studies. And so when we come back to say, okay, reality, apples to apples, it wasn't an apples to apples comparison.
Yeah.
Taking it out, absolutely have to have isolation and high vacuum, like high volume evacuation. So the big suction tips that we use.
Yeah.
Putting it in, the biggest risk is to the person mixing it up.
Yeah.
So the assistants had the biggest risk in mixing because they were mixing the mercury vapors. It's still used today. I think far less. A bigger shift has gone towards resin-based fillings. And then we worried about bisphenols, BPA in them. Plenty of brands now don't carry that. And we're seeing, I don't know if better outcomes is the word. I want to say that what I see in my clinical practice is some of those larger restorations that are silver fillings, because of that expansion and contraction effect, we weaken the walls of the tooth depending on how the tooth was prepped.
Sure.
And then as we bite down with 2,000 pounds per square inch, it hits that teeth and it cracks all around them. And that becomes catastrophic because now, depending on the size of the restoration, and this can be true for composite too, if we have very little actual tooth structure and we've put something in the center of it or we've wedged it in some way, right? If you have it incorrect, if we haven't managed the bite correctly, those teeth can crack all around that filling. And now we're into crowns. And depending on how deep that filling was, if we're into crowns, that leads to root canals or catastrophic failure, and we're into implants.
Right.
There's really nothing that is as natural as your own tooth.
Totally.
Right? Like implants are a wonderful, wonderful invention. I love them, and they have their own problems.
Sure.
And anything else, in between is a compromise. And so we have to remember that.
Right. And I've had seen patients, and especially when I was a student, we saw a lot of low income at our student clinic, patients that couldn't chew, couldn't eat, and they're like nutritionally deficient in, like actually deficient in things because they can't eat.
Right.
They're drinking like the little protein shakes that, Medicaid would pay for, which is better than nothing. Yeah. But the fact is that we need to take care of our teeth so that when we're in our 50s, and I saw patients without any teeth in their 50s, or ideally into our 80s and 90s, and I have patients right now that have fantastic teeth. They did a good job taking care of them, and they're in their 80s and 90s, and I'm so impressed with like how they cared for their mouth. And I'm like, God, I wish that more people had the understanding that maybe they were just born with like good genes. I don't know, but
genetics always play a role in our health and our oral health, right?
Yeah.
So that's where it always becomes about understanding each individual's specific risk profile, their genetics, what played a role in it, and then tailoring any recommendations for prevention to that. Yeah,
and there's so many options that people can do, but dentures, it's still, nothing is the same as your real teeth. So one of my big interests is making sure that we understand how to care for our teeth so that you don't have to have these problems. And
I think it needs to be said too that there's a saying in dentistry that everybody gets teeth, but not everybody gets to keep them.
Yeah.
And it's a sad reality. I think it's important that people know, more often than not, it's not your fault.
Yeah.
If you were somebody who lost your teeth, I think dentistry got into a bad name where for a long time, in trying to get the patient to have ownership, we put too much blame on them.
I see.
And not understanding the roles that genetics played into it.
Yeah.
And so having that compassion to say, okay, life handed you this card, right? You got dealt this card, and sometimes that sucks.
It does.
Here's what we can do. And so then making educated decisions based on the risk.
Totally.
Right.
Well, and there are definitely some things, frankly, that are the patient's fault. Are you an alcoholic? Do you smoke meth? Any of these substances, like my former brother-in-law has had, I don't know, like maybe 10 implants, but he lost a lot of teeth from smoking meth.
Yeah.
And patients, the most common reason I see patients without teeth is because of previously being an alcoholic. It just degrades our bone, and our teeth can no longer hold into the little bone that has been degraded. And so yes, genetics plays a role, and also eating ultra processed food and drinking soda every day.
Right.
Yes, and also then you have your risk of your genetic profile. And the state of the United States right now is our health is not great.
No, I think maybe what I mean by this is to say understanding the genetic risk so far that we are predisposed to this.
Right, predisposition.
And then making the decisions to understand, hey, if in my life my mother had these cardiovascular issues, I can go and eat certain red meats every morning for breakfast, lunch, and dinner. I can not exercise. I can do, I can smoke a pack of cigarettes a day. But that's going to mean that I genetically have a much higher risk of, the same cancers that she had. And so understanding that if my parents had, these oral diseases or this disease, that there's that link there, then, okay, you aren't the kind of person that gets to brush once a day and not floss, and you're not going to have decay. You do that, and you're going to have decay, or you're going to have gum disease, and you're going to run the risk of losing your teeth to that. And then, just like you said, we lose teeth, and we are fortunate that we have things to replace it, but it's not apples to apples.
It's not apples to apples, and not everybody can afford them. There's so many pieces that go into it. Again, like thinking about people's like financial state. Dentures are not cheap. Implants are. I don't even know if implants are covered under insurance.
Some. It depends on the plan. More and more are getting better, but oftentimes no. It depends also who's placing the implant. Are they an in-network provider?
Right. All the complexities of insurance that make me want to break things. Yeah. Okay. So this seems like a good place to get into sleep disordered breathing. Sleep disordered breathing. Most people know sleep apnea. That's the worst of the sleep disordered breathings, and it's really been maybe the last 10 years that sleep disordered breathing's even like a spectrum has even gotten wind. Like people are actually paying attention to it besides just sleep apnea.
Sleep disordered breathing, I think, in the world of dentistry is something that is becoming more and more popular for us to talk about, rightfully so. We see so many signs of sleep disordered breathing, airway obstructions in the mouth, and we need to have a bigger role in assisting the population to get the help and care that they need. And so it's difficult because it really depends. I get people all the time that come in, they tell me, I have sleep apnea, I use my CPAP, I hate it. Is there things I can do to get off of it? And it really comes down to what type of sleep apnea do you have?
Right.
What was your test scores? Do you have other signs and symptoms, So dentistry's role that I'm aware of at this point in time is really a screening tool and helping those patients to adapt in certain scenarios where we have lower scores, mild to moderate scores. There are dental appliances that can be fabricated to help in those areas. If you've got complex sleep apnea, you're probably going to be on a CPAP, but not everybody's tolerant to the CPAP.
Totally.
So that's where myofunctional or myofascial therapists get involved, learning how to breathe with our diaphragm, training the throat muscles, all that can be helpful.
What's a myofunctional therapist?
So myofunctional therapists typically are hygienists that go on to do additional training, and what they're doing is sort of an occupational therapy or physical therapy. I don't want to dumb it down. It's really important. I'm not saying that occupational and PT are not important, but myofascial therapy specifically trains in the neck muscles and breathing. So retraining tongue positioning, tongue posturing, lip posturing, proper swallowing technique, proper breathing through, like with the diaphragm, all can help those things. So if we've got somebody who can't close their lips properly, we have to ask ourselves why. Is it because of a lip tie? Is it because we can't breathe through our nose, and so we're constantly breathing, through our mouth? Is it because the way that the jaw grew, right, and it hasn't fully formed? It's either underdeveloped or overdeveloped. All those things factor into proper lip closure, proper swallowing, proper eating, and resting. So when we see kids who snore, that's not normal.
No.
Like no child should ever snore. So bedwetting is another sign. ADHD, concentration problems.
Right, and that makes sense to me, because if you're not getting good oxygen while you're sleeping, which is supposed to be the most restorative thing for us to do as humans, that makes sense that you would be irritable and like grumpy and hyper the next day, because now you're like, I got to catch up on all the fact I didn't get any oxygen, or I didn't get adequate oxygen while I was sleeping.
Yeah, some of it can be the fact that there is that going on. We have to look at the development, because kids, it's difficult with kids because there's so much growth and development that goes on, right? And so if we have underdeveloped jaws, if we've got underdeveloped maxillas, all that can impact how the rest of the structures within the mid-face grow. And when that's underdeveloped, we have a problem that there's not enough space for things, right?
Yeah, something I see, and I always give the example, did you ever watch Hey Arnold when you were growing up?
Yeah.
I forget what the kid's name was, but he breathed like this.
Yeah.
That guy, severe allergies. So the mouth breathing, the tucked in, what's it called when your chin is like really deep in?
It's a retruded jaw.
Retruded jaw, yeah. And so he couldn't close his teeth properly. He couldn't close his lips properly. So some things I see is allergies and hiatal hernia formation, which is where your stomach slides up into your esophagus, your throat, and restricts that lower esophageal sphincter. So this is, again, here I am with like focusing on the mouth, because I think about the digestive system so much in my practice. And allergies, believe it or not, like our nose does so much to prevent us from having allergies. And if we can't breathe through our freaking nose because it's stuffy, and this is like the weird thing about it, is the more you breathe through your nose, the less stuffy it is. Yeah. Because of nitric oxide. But if like functionally, because your physiology, your anatomy is as such that you cannot breathe through your nose, then we need to go down a path of considering maybe even surgery in some cases, depending on, you know, if it's a kid that still is able to grow and adjust and get like, what are those palate extenders and...
MREs, like maxillary rapid expansion, palatal expanders, different things, right? So we look at, on a basic level, you know, things such as humidifiers in rooms can help open up nasal passages.
Hugely. Especially in dry, negative humidity Colorado.
Yes, where we live. Mouth tape has become really popular. There's a couple companies out there that do it. Scotch tape probably isn't going to work that well. Some people get away with it, but actual adhesive tape, believe it or not, if you cannot breathe through your nose and you tape your mouth shut, your body will dilate and open up those bronchioles, open up everything, all the passageways. It might not be a beautiful breath, but it will be I can just get enough air through this nostril situation. Your body's amazing in how it adapts. I don't think anybody should just go out and tape their mouths without talking to the professionals and finding out what's best for them.
Right.
But there's little things we can do, right? There's when it's obstructive sleep apnea and it's because of the muscles relaxing and collapsing, maybe it's our tongue, we've got tongue ties, or we've got the tongue throwing to the back of the throat, things are restricting our airway. That's where dental devices can be, mandibular orthodontic positioning devices can be beneficial to position that jaw forward and lock it in place and lower those scores, lower those apneic events.
So have you seen... So definitely we're talking obstructive versus central. Central is like a nervous system thing, and like, sorry, you have to be on your CPAP. I don't have a good solution. But we're talking about obstructive, where there's weakened tongue muscles, weakened throat muscles. There's a crazy study I saw about didgeridoos, and you play 20 minutes 6 days a week for 6 weeks, and it can reverse obstructive sleep apnea. Why? Because you have to use these muscles in your mouth and your throat. And it's I've never played a didgeridoo, but there's like a musician I really like. I'm forgetting his name right now, but it's like a very complex, like circular breathing action that you do. Right. But again, who's going to go run out and get a didgeridoo and start playing it?
No, I think that's where myofunctional or myofascial therapy comes in. To teach you, all right, there's these exercises you can do for proper tongue positioning, for proper development. I think the biggest thing is screening kids when we're young for those things. So I've seen kids where we automatically notice that they couldn't close their lips. They didn't have proper lip closure, suctioning, eating was a problem for them. Mallampati scores, right? We start seeing those more closed airways. We can't see the oropharynx. That's a concern.
Yeah.
The parents didn't report any bedwetting, but the child would roll to her tummy, kind of get into a ball, lean to the side, and breathe through her mouth. Mouth breathing, snoring of any kind wasn't normal. So automatically, like, I think I was at training, came back, called the parents up and was like, hey, you've got to come bring her in.
Yeah.
And we worked closely with the ENT and the orthodontist and the myofascial therapist to start getting the kid treated. So we removed adenoid tonsils that were, they were massive, and we see that so many times in kids.
Yeah.
And if it's not allergy related and it's not cold related, it's not normal.
Right.
And you can bet if I saw it this time and I see it again 6 months ago, it wasn't because you had the sniffles at this appointment.
No.
Right. So
Right.
getting tonsils addressed, hitting those early warning signs, and then saying, okay, yeah, craniofacially they're not developing right. We need expanders. We need this. If we can catch those things early on for kids, it's almost as if we didn't recognize that there was a problem to begin with when we're done, right? We caught it early on and we corrected abnormal growth into normal human being. And I've had plenty of people say that, like, oh my gosh, my daughter won't stop eating, my son won't stop eating. Like, now that we've done this, their appetite's huge, right? And so we're seeing already like those minor changes, and as an adult they won't know any different,
Right.
which is huge.
Right, because they can actually swallow more appropriately because those muscles, the nervous conduction is like actually functioning properly.
Yeah.
It's so interesting. And just so people know, the Mallampati score is seeing your tongue when a doctor does or a dentist does an exam of your mouth. It's where your tongue sits when you do or take a breath in. And can you see the little uvula hanging down the little punching bag? Yeah. Can I see the actual back of your throat? Which in so many cases, I don't know, maybe 50% of my population, I can't see the back of their throat. I barely can even see their uvula. Yeah. I'm like, okay, I'm worried about sleep disordered breathing, and it's usually tongue is like way back deep in there. Yeah. So do you have a myofunctional therapist at your office?
I don't have one at my office. There is one in town here that we work closely with.
Oh, fantastic. That's good to know. Great. I'm really happy to hear about that. There's so many negatives about social media, but there's a lot of good too. And some of the things that have tuned me in is like I started following this lady, Jen's jaw surgery, and she had like messed up palate. She's had a number of surgeries, and she's shared her story along the way, and it's been really not only inspirational but educational. Of like, she's like, hey, mouth breathing is a serious problem. Like, if you see kids doing it, she's just like, close your lips, and she's the one who kind of tuned me into the myofunctional therapy and that you can train your tongue. What about teeth clenching and teeth grinding?
Yeah, great question. So teeth grinding, acid erosion, scalping of the tongue are all signs of a potential airway issue. Yeah. And so in adults, when we see that, and sometimes even kids, right, we have to ask ourselves specifics. So if I see acid erosion, and I think I've shared with you, it's really frustrating that I feel like not enough people know what the difference between acid erosion and grinding looks like. Can't tell you how many people have come in and they say, my last dentist said that I grind my teeth. And we take one look and I go, you don't grind your teeth. You might clench, but you don't grind your teeth. That's acid erosion. These pits and these craters, when the enamel is higher and we have a hole in the center and it's deeper. Grinding doesn't do that. Grinding, it's like a mower. It just flattens it. Acid erosion breaks things down and we get these little spires. So peaks and valleys within the tooth surface are signs of acid erosion. And then we have to understand why, right? Is there issues of it's internal? We've got trypsin and pepsin coming back up. Do we have acid reflux? Do we have silent reflux?
Yeah, gaseous reflux as opposed to liquid, which in my opinion, I think is more common. I think silent is significantly more common. It's atypical reflux is what we refer to it, and I think it's unfortunately typical. Yeah. So
we're seeing more and more of that coming out. Yeah. We're not seeing more and more of it. I feel, well, maybe we are, but I feel like we're better recognizing it and identifying it. So many of these things we thought before was just, oh, you grind your teeth, here's go get this, go get a night guard.
Yeah.
We really need to start looking and saying, what's the bigger picture here, right? It's a neurological impulse, but why? Is it because, frankly, like there's certain medications that cause that brain synapse that can be more prone to grinding? Or is it the body is responding because it's not getting the room and the space and the air it needs, right? So when we see that scalloping on the tongue, we have to ask ourselves, is the tongue too big for the space? Meaning like the tongue is too big, or is the space constricted? So in our airway exams, we're looking at the canine distance. So from one cusp tip to one cusp tip on your maxillary, we're going to measure that. We have, specifications of what's normal, what's shallow, what's wide, and vice versa. We also do the maxillary molar teeth. So we're going to measure from the buccal cusp tip to the buccal cusp tip. We're looking at high palates. We're going to screen for mal-and-patty, but then also dental class profiles. So jaw positions, right? Are we retruded? Are we normal? Are we extended? What does the facial profile look like? Are we mesocephalic, brachycephalic, docephalic? All that in and of itself, each one is not a single predictor, but together we start creating a profile and an understanding of what the risk is.
Got it. That makes sense. Mesocephalic, brachycephalic, and what was the other one?
Docephalic.
Docephalic. So I know brachycephalic because I have one of those stupid flat-faced dogs. So more flat-faced. So can you kind of break down the other two for us?
Yep. So mesocephalic, would be considered, you and I would be considered mesocephalic. So it is a relatively normal profile where we're not too wide and we're not too long. Okay. Doce would be really long. See like the really tall men with the really elongated faces. That's going to be Doce. And then your brachycephalic is the widened, right?
Widened faces.
And often you have to be careful because it can be hidden by beards, especially for men.
Okay, for sure. I could see that. Yeah. Well, that makes sense, though, that the longer would be a problem, probably have more narrow palates then.
Right.
Yeah.
So in the longer faces, we see the higher palates.
So scalloped tongues. So this is so interesting to hear your perspective on this. In Chinese medicine, a scalloped tongue says that there's liver issues. The liver is having some stagnation is what we call it. And so that's how I treat it. And I've seen it go away.
Interesting.
So I support the liver, help the liver do its job, which again, everything, the mouth. I think about the mouth very much from a digestive perspective. Mouth is showing me symptoms. Well, maybe it's telling me, and I'm not a Chinese medicine practitioner, I know enough to be like, I need to refer out, or can I use what my little knowledge I have and kind of see this as a symptom and treat it appropriately and see it go away. And I mean, I feel like a broken record. I am talking about liver support almost every patient. Sometimes it's kidneys instead of liver, but liver all the time. Whether it's reflux or not, liver is how I treat it. So interesting.
Which I imagine isn't a terrible approach considering that the liver is our biggest detoxifier.
Correct.
And with everything, at least in America, the food that we eat,
the air we breathe, the water we drink, the clothing we wear, there's so many things to it. And the way, the other component is bile. Liver is the producer of bile. Liver then makes bile and it stores in the gallbladder. If you don't have a gallbladder, even the body sometimes makes a little secondary sac. It's not quite the same, but I think about that as a clogged U-joint. You got a bathroom sink and it starts to overflow, and thinking about that as the mouth, and that's reflux coming up. Again, we treat the liver and things seems to start flowing in the more appropriate direction. It's so bizarre. It's a little more complicated than that. Sometimes, it's we need digestive enzymes in the stomach, but it's really interesting to see symptoms in the mouth and then be able to get them going in the right direction. But it's the ones that I don't get traction that I'm what do we need to do? Because who loves going and getting a sleep study? No one.
No one. Well, and it's interesting what I've seen the difference between going to the sleep center, because in my mind you're hooked up to dozens of electrodes.
Right, not just a pulse ox, which is so menial in my brain.
Except high resolution pulse oximetry is, I think, critically important for proper diagnosis of sleep apnea. Right?
I'm sure the tool I'm using that I like loan out to patients is like a in-between step.
Yes, and I think it's the difference between like a high-resolution one and just a normal pulse ox.
Yeah.
So high-resolution pulse ox, and then home tests become really popular, and I'm a fan from a standpoint of how better are we recreating your natural sleeping pattern.
Totally.
Again, the correct devices are necessary. Not every device out there is created equal for testing that.
Yeah.
Something that I'm curious and looking more into is upper airway resistance syndrome. It's not commonly talked about, and oftentimes when we pass our sleep tests, when everything looks fine but all the symptoms are still there, that is where I am pushing and going off to train and learn more about what's going on and how is this impacting us.
What exactly is that? I've never heard that term.
So think of upper airway resistance syndrome as everything. If obstructive sleep apnea is here, it's in the throat, upper airway is above.
Oh, sure.
Not including the brain.
Right.
But
Oropharynx.
Deviated septum, too big of, I'm going to say I'm wrong, things inside your nose, nasal
sinuses, turbinates.
Nasal turbinates. Thank you.
Please do not remove them. I am so sorry. I am very against that surgery. I think it is incredibly barbaric.
Yeah,
it causes anxiety disorders for the rest of your life.
I've had some friends that have had it done, and it looks horrible. But that being said, deviated septums, massive nasal turbinates, just the upper airway being constricted in some capacity, right? The studies that I've seen, and I'm not sure if this would qualify under upper airway, would be hypodevelopment of the mandible.
Okay.
And as we look at the nasal passages, how that closes the windpipe, right? Like
so this is like that Arnold character.
Yeah.
Yeah. I bet you his turbinates are big because that guy had major allergies.
If we look at airway CBCTs and we see and we're monitoring growth and development, all of a sudden our airway on a CBCT is here, and a year or two later we're looking at the child and it's this big. We've got a problem.
Definitely.
Right? The natural craniofacial growth and development is no longer normal. And that's where then, in my mind, it gets into surgery, right?
Yeah.
It's mandibular advancements, it's expansions, that type of stuff.
Yeah. Probably easier to do things that are less invasive. I'm trying to choose my words carefully here. If we catch this in younger populations that are still developing versus, a 40-year-old patient like this Jen's jaw surgery lady that I follow on Instagram who's had 2 or 3 major facial jaw surgeries to correct some pretty serious issues, and you can see her face before and after, and it's crazy. She had the long, what did you call it, mesiocephalic?
No, that's
docecephalic, really crazy, and gummy smile, no more gummy smile, normal jaw, definitely more of the typical facial normal developed face.
Right.
Crazy dude.
Yep. So, and in those cases, I don't do the surgeries, so I wouldn't be able to comment on when it's appropriate and not, but catching it early I think is critical, right? To say whether or not if we caught it early, it wouldn't have necessarily prevented a surgery.
Depends on how severe it is. Yeah, there's a spectrum.
There's times when surgery is absolutely necessary. Totally. There's no device, no amount of those things are going to change it. What I think is important to recognize is that sleep apnea, whether it's obstructive, central, complex, upper airway resistance syndrome, there's never a one-size-fits-all treatment with it. I think even when we have CPAPs to help us, people can benefit from myofunctional therapy.
Totally.
Better breathing, because the CPAP's only doing the work for you during the nighttime.
It's forcing,
right?
Yeah.
And learning proper breathing techniques can help.
Yeah.
The other thing that I wanted to talk about was, it's really interesting, I get a lot of this feedback from patients who are on CPAPs, is the dry mouth.
Yeah,
massive.
Hate
and
it.
That can sometimes stop them from complying.
Yep,
and
totally.
so it becomes this balance between how do we comply with the devices and or medication we need to treat the body, right? That's critical. Oral sleep apnea can potentially be life-threatening in how it affects the rest of the body and the systems,
Definitely.
right? We have quality and quantity of life at question.
Yeah.
And how do we deal with the symptoms it gives us?
Right.
So orally, the symptoms it gives us is dry mouth, and dry mouth is the number one hardest thing for us to treat, right, preventatively. I get really aggressive on the prevention when I have patients who have dry mouth.
So I'm curious what you use, because there's this herb that I'm familiar with, and maybe you are too. It's called toothache plant. And what it does, it's called a saliagog in herbal medicine, as in creates saliva. And it's like, you have one little button of this plant. It's a flower. What's it called? I'm forgetting what its name. Alchemilla something. Toothache plant is the common name. Anyway,
toothache plant.
You take one little like thumb-sized bud, and it's the flower that you eat, and like you will be producing saliva like nothing else.
Okay, I would have to check into that. I haven't heard as much about that. So when we have dry mouth, we have acidic environments.
Oh yeah.
So it's like the extreme form of cavity prevention, right? A lot of times it's used we use xylitol. If patients if they don't have a gut reaction, we're going to use xylitol. Okay. So there's mints that have xylitol in them that they use at nighttime that seem to help and stimulate a little bit. We can use, again, humidifiers help, staying away from alcohol, staying away from caffeine. Humidifiers, yes. Sometimes sugar-free lemon drops or sugar-free candies to stimulate that saliva flow.
Yeah, something tart.
Yep, to stimulate that. Pilocarpine, and I'll slaughter this pharmaceutical name. I always hate how they name drugs. Cimelavine. There's 2 drugs out there that can help stimulate saliva. And in patients who have severe, I don't do this necessarily for patients who have dry mouth due to sleep apnea, but my autoimmune, Sjögren patients, we look at those options. The hardest part is you can't be on any other medications if you're on it. Like there's so many drug interactions. So it's a very small subset of patients who can do it, but in the ones that it works, it's fantastic. Like they can't stop drooling. So that's nice.
This would be an interesting thing. Maybe we can talk about collaborating on this. Is like, I have thought of when I first learned about this, I haven't had any Sjögren's patients that have had dry mouth, I'll say. And
I only have Sjögren's patients that have dry mouth.
So I've seen them with dry eyes.
Okay, yeah.
I treat that with castor oil in the eyes.
It's interesting because I actually was talking with one of the hormone specialists here in town, and we were talking about dry eyes, and it started getting me thinking, like, my patients who have dry eyes, even though I might not be seeing the signs in dry mouth, could they be treated in similar ways, right? Like there's hormones imbalance. They're using hormones to treat it, but the balance of what's going on in our bodies, and do we get one or the other? Because it absolutely, hormones affects the mouth.
Oh, absolutely, everything. Like, this is what's crazy to me about conventional medicine. You've got a neurologist, you've got a cardiologist, you've got a gastroenterologist, you've got a genital urinary specialist or urologist for men, and a OB-GYN for a female-bodied individual, and they don't think that those systems talk to each other. But you know what is connecting every single cell in our body? Our nervous system, our immune system. And I would say that our hormonal, our endocrine system,
and cardiovascular.
Well, yes.
Yeah.
So like, again, you can't suction off and like, we're only seeing a cardiologist when we have high blood pressure. But actually, you could have obstructive sleep apnea that's causing your high blood pressure. So now you need to go in and see a neurologist or sleep specialist or like, it's too sectioned off.
Yeah.
We've become too specialized.
I feel like that's a product of insurance-driven models and where medicine is at, and private equity and all that. I think the average doctor, if we talk to him, knows that it's all connected and
totally
wants to treat the whole person, right? It's a matter of, is it allowed between the hours of 8 to 5?
Right.
Can I do this and still maintain the load that's put on me?
Right.
And so where I'm curious is to see how we can start opening our eyes to be unbiased about, like, okay, it used to be we would look at the mouth and we would say, oh no, it's not a tooth problem, it's not my problem.
Yeah.
Right?
Right.
And now taking the approach to say, okay, it's not, the cause isn't the tooth, the cause isn't the gum tissues. You have an issue and it's showing oral signs.
Yeah.
But let's break it down. You have this, and this symptom. Your symptoms are more in line with like immune issues. And
Yeah.
so let's get your primary involved, and let's talk to an immunologist. Let's talk to, or let's talk to a rheumatologist. Let's go see what we need to do to get you more in line with what's going on.
Totally.
Because I can topically treat, mucous membrane issues, but that's not actually treating
it's superficial
the issue at hand, right? I can treat signs of gut issues in the mouth, but I'm just throwing Band-Aids at it. So that's where in our practice we've really tried to slow down and stop and say, whoa, like this is, okay, it's not, but it's not that it's not my problem and go figure it out yourself. Yeah. It's to say, all right, let's think about this. These are the symptoms, these are the signs, have what is the physician said, and if the physician hasn't been able to come up with it, and yeah, that's frustrating when they're they have 5 minutes and it's, oh, that sucks that you have that.
Can I write your script?
Yeah, or just there's no answer.
Right.
So pushing forward, trying to find the answer. To me, it's no longer acceptable to say I don't know.
Yeah. Right? The better answer is I don't know, but let me find out.
Yeah.
Or let me get you to a person that does know.
Right.
It's like we should be doing these pieces for our patients, and I understand that insurance ties our hands. This is why I don't take insurance, because I actually want to be a practicing doctor and help my patients get better. And I'm not saying that other doctors don't, because there's a lot of red tape. There's a lot. It's, again, one of those nuanced, it's not such a simple black and white solution.
Right.
It's like you kind of get pigeonholed into this is the way we have to practice. And I don't know if you kind of got this messaging when you were in dental school, but I was told over and over, there's no way you can have a cash-based private pay practice and be successful, and that's not been my experience so far.
No, and I think there's room for all the options.
100%.
Right? Like, I have a large cash pay basis in my practice, but I also am in network with insurances, and I take insurance. Mm-hmm. And I've had to shift my business model and my way of thinking to say, it's not about, when it comes to treating, I always treat the patient, right? I'm not going to let an insurance company dictate how I treat. But it's more about understanding that there's a number of people out there that truly rely on that benefit. They're paying for it and they want it.
Totally.
And that's okay. Mm-hmm. And shifting it to explain to them the limitations of their plans, and that you may need things that are beyond what is reimbursable.
Yeah, totally.
Right? And the frustration is the companies and their pushback to us, right? And we get caught in the middle.
Yeah.
And so that's why I work with the state organizations for insurance reform and medical loss ratios, dental loss ratios, to say these massive corporations and taking everybody's money, but then saying we're going to spend it on patient engagement, and their idea of that is let's hand out t-shirts at a football game. And I bet you if you would just pay for the procedure and not have them in dentistry, it's a portion out of pocket every time. There's very few procedures where the patient doesn't have a co-insurance or a copay of some sort. Yeah. And only 6% of people nationally hit their dental insurance maximum benefit. Wow. So there's no incentive for the insurance companies to pay and bring up higher level of benefits, right? Like if my maximum is $1,000 and it's been $1,000 since 1960, what's the incentive to give you $2,000 when you have not ever hit that maximum benefit? Right. But they haven't hit. It's not that they haven't hit the maximum benefit in what they need. It's because they have a hard time coming up with the other $500 to cover the service that's needed. Right. Whereas if the insurance would just say, okay, we're going to pay for 100% of it till you hit this. Right. Far more people would hit their max.
Right. And I mean, it's eyes and dental are typically the things that are not included in your average insurance, and I guess we just don't need those. Yeah. It's like, that's me being flippant, but the whole thing is those are very important. It's like if I have a patient that comes to me and they're saying, hey, I'm having eye pain, I'm like, how long has this been going on? Are you having any changes in vision? Great, you're going to go to see an urgent ophthalmologist, the medical doctor, eye doctors. Like we don't mess around with those things. Right. And anybody that's had tooth pain knows, like, tooth pain is like terrible. Yeah. And you're more, what's the word, motivated to like get something done when it's an urgent thing than when it's like, oh, I just need to get my preventative cleaning twice a year. I need to get my eyes checked every couple years if vision issues aren't an issue.
Yeah. And it's hard too, right? The body talks to us and it tells us when it's in pain. Teeth are very different. They don't work like that. When your tooth is in pain,
bad.
It's not a good situation. It's like a heart attack, right? So that is a shock factor for everybody when they have gum disease or when they have a bite disease or when they have a cavity, because I didn't know. Right? It didn't tell me anything. I wasn't having problems. Occasionally the tooth hurts and it's cracked or it chips and it breaks and you know it. But by the time you can tell me you have a cavity, it's a problem. Yeah. It's a massive cavity. It's into the nerve tissue and it's no longer a filling. It's, it's either removing the tooth or it's root canals and crowns and everything else. Right. And so that's where we have to be vigilant in preventative medicine and checking things out versus waiting until there's a problem.
Right, exactly. And I mean, what is it, like 67% of Americans live paycheck to paycheck, and that's, speaking to a larger issue. We don't have time for that right now. But.
No.
So we've talked about a lot of really good stuff and like really trying to help our audience unpack some of the complexities that come with dentistry, the nuances that show us, hey, like systemically our mouth is speaking to us, and usually it's a capital P problem by the time it's showing up in the mouth. Things like autoimmune and cancer and sleep disordered breathing and GI gut issues can show up with mouth symptoms. We talked a little bit about fillings. Both amalgam and composite are the most common. I think I've got maybe like 2 or 3 like older patients that are in their like 70s that have like gold fillings or gold caps, gold crowns. They do look a lot nicer than the silver ones. We talked a little bit about fluoride and understanding the pH of the mouth and how pH of toothpaste is important for us to take into consideration. And while the nano-hydroxyapatite sounds like a good idea, it's a little more complex in that we need to know the size and shape of the hydroxyapatite, and none of the toothpaste that are currently on the market help a person shift a more acidic pH to a more neutral, balanced pH.
There's a company on the market, it's the company we use, that does do the shifting. Okay. They have a pH neutralizer in it.
Got it.
I love their company. I love the research and all the science they do. They just don't have a nano-hydroxyapatite, SLS, glycerin, paraben-free one at the moment. They are working on one. Okay. Right? So these companies that we see that have glycerin-based products, there's challenges there, right? How do we get things to stick? How do we get things to work, right? To adhere together, hold it all so that we can get that paste. So the company I work with has a fluoride-free line. And it's still my go-to line if a patient doesn't want to have fluoride in their mouth, because it has the pH neutralizer. They're the only company out there that has a pH neutralizer there. So it's there. It's just then when someone comes to me and they say, okay, I want SLS free, I want paraben free, I want fluoride free, I want this, this, and this, that doesn't exist. I recently saw, I got an email from a couple doctors asking if, what was it? It was a powder, and I can't remember. I looked it up and it was interesting. Eggshell powder toothpaste.
Interesting.
Yeah. I couldn't find anything. There's no research on it.
It seems slightly abrasive, and
that was my thought. Was what's the RDA value? Like, how abrasive is this?
Interesting. I always get. I'm not sure about that. Interesting.
I think we have a problem, and it's a systemic problem in America, that there's a population out there that wants everything natural and holistic.
Right.
And there's nothing wrong with wanting that. It's a matter of understanding the realistic limitations, because too many companies have taken advantage of it.
Right.
They put things out there that say, oh, it's all natural, oh, it's all this. Well, did we actually get into the conversation of labeling and laws?
We didn't, and how petroleum can be labeled as all natural because it's technically from the earth, and it's like, technically speaking, it is, but
so okay, it's great that, I had to tell my husband the other day, it's great that the cereal you bought didn't say artificial flavors, but guess what? Natural flavors is
still
artificial.
still highly questionable.
Yeah. So there's a lot of shadiness in the labeling practices that go on, and
totally, you really have to be astute to understand what the freaking label is even telling you. And honestly, if your product has a label, I don't know, it shouldn't be telling you it's heart healthy. Apples are good for you. We know that.
Yeah. So the same is true in our line of care, right? And I think we touched on floss, but you and I spoke earlier about PFAS. So a big thing on floss too is be careful, like the plastics that you're using. There's a really well-known brand of floss that's in big litigation right now for PFAS. And
it's like perfluoro, so it's fluorinated. It's the slippery, the non-stick, wrinkle-resistant, waterproof. Those are and super slick.
I always really disliked that floss too, because it's
very thin. That's what I didn't like about it.
And it just goes around things. It just if you got something stuck between the teeth, it didn't actually get it out. It just like slided right past it. So I kind of thought their name was perfect for them. There's better products out there, but just because it's all natural or that doesn't necessarily mean it's A, effective, and B, healthy for you.
Well, when we talked briefly about SLS, sodium lauryl sulfate, we don't need everything to be foamy. Clean does not have a smell. Actually, clean is neutral smelling. There's no smell, no aromas to it. There was like some marketing thing like minty fresh. Like, you don't need minty fresh breath. You just need a clean damn mouth. No biofilms. That's it. Like, you don't need minty fresh. You don't need foam to have clean. Foam, sodium lauryl sulfate, SLS, is a mucous membrane disruptor. It's an emulsant. You don't want that. Period. You don't want that.
It's interesting. If you, I don't get any of my dental products from the grocery stores, but in a pinch, if I did, there are absolutely ones that I would avoid, because I have found even some of the most common ones made by very well-known, there's a couple, just a handful of companies out there that make toothpaste. You got your Crest, you got your Colgate. When I brush my teeth with those, I notice sloughing of my tissues. And it's absolutely, the SLS, which you can have allergies to it.
Definitely. I did an undergrad research project on it in relation to African clawed frogs, because I have sensitivity to it. So that was something I learned about well over a decade to take out of my personal care products, because it's in lotion. Why is it in body wash? It's in freaking everything.
It's because it's a surfactant. And so it gives you that sudsy, foamy feeling. And marketing companies have been very successful in attributing foamy feeling to clean. And it has nothing to do with each other.
So much of marketing is just like psychobabble baloney. And if you understand psychology, you can start to see this and be like, you are marketing to me right now, motherfucker. I'm not pleased. I see you. I see what you're doing.
I know. I've gone and not researched, but watched videos on the layout of grocery stores.
Oh, totally.
And there's a reason why milk and eggs are in the back, right? Like, they're staples in most people's diet.
You have to go through the whole store
to get it.
Well, and if you go to the grocery store section with all the produce first, which is what they try to get you to do, you feel less guilty about your splurge buying of the cookies and the candies.
There is a mastermind in everything from restaurants, how they're set up, to grocery stores, how they're laid out. And so once you know it, you can be a little bit smarter about it.
Yeah, for sure. And this is why you don't go to the grocery store hungry, because they get you.
Go with your list for sure.
So, Jill, where can people find you if they want to get in touch with you? Do you do any social medias, getting on your website? Just let people know where they can find you.
Yeah, absolutely. So Montrose Dental Wellness is our company. If you go to our website, you can Google Montrose Dental Wellness, or it's www.montrosedentalwellness.com. We have both Facebook and Instagram pages under that name, and happy to help you out. Give us a call, and we'll get you taken care of. I can guarantee you that the type of experience you have, just even in the day-to-day, your hygiene therapy, your periodontal therapy, will be unlike almost anything else you will have ever had. We really put in a lot of time, effort, and research from companies around the globe in trying to bring better care to our area. I think so many people get stuck in the Profis and the Pace and the Cabotrons. We wanted something completely different, and I just kept saying, in all the techniques and all the trainings and everything that we do as a dentist to bring better stuff to our patients for procedures, there's got to be a better way to do hygiene.
Totally.
So we're excited. Thank you.
So you're saying you're not just a drill and fill dentist. I love that.
No.
Yeah, thanks everyone for joining. If you really enjoyed this podcast, share it with someone that could benefit to learn a little bit more about dental health. Someone maybe that's dealing with potential sleep disordered something too, because this is a newer conversation that the medical community is having. Like and subscribe. My next guest is going to be a certified breathwork coach, and I did anticipate specifically this conversation and then getting breathwork on board. Breathwork is something that changed my life. I've seen it change patients' lives. It can be very profound. So stay tuned for that next episode, and thank you guys so much for tuning in.